Okay, I think it should work now.
Okay. All right,
Perfect.
we'll go ahead and get started. Chair Sexton, I'll hand it over to you.
Okay, thank you. Good morning, everybody, and welcome to the public meeting of the Patient Protection Commission. My name is Bethany Sexton. I'm the chair for the Patient Protection Commission, and I'll now call this meeting to order. Dylan, if you want to get us started, that would be great.
Yeah, thank you, Chair. Commissioners, please identify if you're present when you hear your name called. I'll start with our voting commissioners. Dr. Jonathan Chastain is excused absent. Dr. Mark Glyman.
Here.
Dr.
Here.
Ikram Khan. We'll mark him here when he arrives. Marilyn Kirkpatrick.
Here.
Dr. Andrea Peterson.
Here.
Dr. Adam Porth.
Here.
Dr. Travis Walker.
Here.
Chair Sexton.
Present.
Moving on to our non-voting ex officio members, Insurance Commissioner Ned Gaines. We'll mark him present when he arrives. Director Stacy Weeks.
Here.
Executive Director Janelle Davis. She is also excused absent. And Executive Officer Teresa Karsten. We will mark her present when she arrives. Chair, that concludes roll call, and we do have a quorum.
Excellent. Let's move on to public comment if we can.
Yeah, this item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item.
how people know that telehealth exists. So is that, I don't know. My insurance doesn't tell me that I could get telehealth, and I actually didn't even know that UMC had telehealth until I ran into a scenario. But I do get tons of things every day, whether it be in the mail, social media, from Texas, from Idaho, from Utah to use their telehealth. So I was wondering, is that something that we also need to look at, is to at least people know that that's an option?
Having some mechanism for people to understand what the resources are that might be local, but telehealth versions or the like.
Right. Well, and it'll support our own hospitals, you know what I mean? So
Yeah.
that they're not going to these other places.
Well, and having connections from a continuity perspective, if you're seeking prenatal support or other things via some of those telehealth mechanisms and then end up delivering there or whatnot. It's good. Dr. Peterson?
Yeah, I was just gonna ask if we know in the preterm rates, is there a specific area where those numbers are higher, like, as opposed to where most of the providers are in Clark County and Washoe? I know a lot of the high-risk providers, from my understanding, they are only located in Washoe and Clark County. So just kind of curious.
I don't have that information off the top of my head. There is a Office of Analytics data dashboard that has some of those breakdowns by region. It's the maternal and child health data dashboard that we can take a look at and see if we can see any of those trends.
Because I think that does contribute also, as far as like your high risk pregnancies, it's really hard to access, or even harder to access care for those high risk pregnancies.
Great. Are there thoughts about sort of the kind of jumping down to some of the questions about building the supply and recruitment and retaining workforce in some of these areas? Any thoughts from commissioners about any of that? Dr. Walker?
Yeah, I mean, anecdotally and looking at some of the evidence, I can tell you we graduate more medical students than we are able to retain in the state for training. And I think anything that pipelines graduate medical education would be huge across all of those service areas of OBGYN, pediatrics, and family medicine. And then following that up with having pipelines to keep people into the state, or keeping them in the state and not necessarily going to a neighboring state or elsewhere. And I think for me, anything that would pipeline people to just stay in the state, the more time they spend, I think, with residency programs, fellowship programs, as well as having great partners in the state to take on new grads and build them, train them, and keep them here would be the biggest thing. And then same thing on the behavioral health side. More LCSW, LMFT, CPC training tracks, psychology training programs for doctoral, postdoctoral candidates, things like that. All of that would be huge. I know there's a need to focus on the rurals as well, and kind of looking at some of the language of this SHARP grant opportunity. I think focusing on some of that innovation, but not just innovation in the sense of like we want to have those quaternary medical centers. Anything that innovates and brings up some of those rural hospitals and rural community clinics would be huge.
Thank you for that. Commissioner Kirkpatrick.
Thank you. So maybe Stacy, do we still do incentives for people that bring like their corporate office or corporate healthcare scenarios here? Because it might be a way to keep to bring some of those to the rules, or even in Clark County, because I know prenatal pediatrics, all of that is somewhat changing. We don't deliver a lot of babies. There's a couple hospitals that do it, and then there's a high risk one. So, but I mean, I don't know if it's part of the economic development. We used to do that years ago, and I don't know if we still do it.
I can check with that. I mean, I think there are some obviously business tax credits, but I don't know if they're specific to healthcare anymore, and I don't know on that side. Dylan, remind me, let's follow up with the Office of Economic Development on that, and maybe Dylan.
I'm not aware of any at this point,
Okay.
but we can
Let
look
us
into that.
look into that. I do think that's important. We do have the SHARP grant that's supposed to help with some of that too, to give kind of some seed money to get people to come in and fill these needs, but it's one pot of money, it'll be gone soon. It's temporary.
Well, I think in the 80s, right, when they were trying to get doctors to come here. I know I'm old. I always feel like the History Channel, but we had a corporate grant, which is what United Healthcare started at, and then for 20 years they were getting like $40 million a year, which hence we repurposed those dollars. But it really did start bringing people in, and we found more people that were doing it, and maybe we just need to get back, not quite 40 million, but maybe we need to get back
Yeah.
to something to encourage them to set up shop across the state.
I love that. I mean, real quick on that, Dylan, maybe we ask the Office of Economic Development to come present to PPC about what they're doing in this space, because I know they're doing a lot, Marilyn. But I don't know, like, maybe there is something more pointed like that we should be doing that would actually, that we know works. We worked before, right?
Yeah.
Right.
So maybe we
No,
should
it
be
worked
doing
for
that.
many years,
Mhm.
so.
Mhm. I love it.
That's great. Thank you. Dr. Glyman.
So I just a couple things. Commissioner Kirkpatrick, I was here in the 90s, which was the golden age of getting paid, and we were able to recruit a lot of doctors at that time because we were getting paid what essentially we billed. And I'm not being critical, but after the HPN started in the 90s and all these fees went down and down, we've been progressively losing more and more doctors, even though I agree that we have all these training programs and I'm involved with the residents and so on. They're not staying here. And just for the record, CMS has proposed for 2027 a 1 to 2% across the board cut, along with what Humana is doing in terms of down coding. And while hospitals are getting their cost of living increases, and same with all of the other employees. So as much as we're trying to do here with these proposals, until the federal government or even the state recognizes that you need to have people to service all of these priorities and pay them, it's just not going to happen. And people are retiring at a rate that I haven't seen in years, and they're not being replaced. And that level of skill is leaving us and the community. And it's my last point is that you cannot get corporations to move to this state without good health care and without good schools. And the schools are improving irrespective of the numbers. I sit on these committees for the Ivy League. These schools are wonderful. And, besides Washoe County, Clark County, the education is wonderful, but the healthcare is continuing to decline. And I think that it'll reach a point at some point where the system is going to either collapse or something's going to have to be done. And it's going to cost a lot more money. And in my little world, there's only, we used to have 6 people cover the whole city of Las Vegas for all the facial trauma, 6. Now it's down to 4. And all of us are in our 60s, and we cover all the hospitals, and it's getting to the breaking point where a few of us are going to retire. Not me, but a couple other people are going to be retiring in a couple of years, and it'll be just 2. And those are issues that are occurring in real time and are of concern. And that's on all the specialties like pediatric cardiac surgery, et cetera, neurosurgery. So those are real problems. And I'm not sure that we can do anything about it, but the legislature or the governor has to take these things seriously until it hits them in the head that we don't have the doctors to take care of people here.
Thanks, Dr. Glyman. Dr. Weeks.
Dr. Glyman, I, with all due respect, I appreciate that perspective, but I would say there's a lot of money in the system and doctors get paid a lot. And I want to be very careful that we don't expect that just raising rates is a solution unless you're going to pass an income tax in the state. There's certain things that all of us like here. And so if you want more money from taxpayers and rates and things like that, then we need to increase taxes. And I don't see anyone voting on that anytime soon. So in the meantime, we've got to figure out what we do with less. And I appreciate your perspective, but we can't have providers that just want to make money. It's got to be service too. So I'm not trying to come off and be rude on that, but it's a challenge. Like everyone is taking it seriously, but no one wants a tax raise. So if that's the
And I
case,
agree with you.
what are we going to do
but
on that?
Well, I agree with you, and I take Medicaid, and we take every payer, and I don't really personally. I don't. My practice, we don't care about money. We make money because we provide good care and we take good service. But the economics is that every one of our staff and every one of the employees want health care, they want benefits, they want raises, et cetera, et cetera. And it's fine if things are static, but when people are getting pay cuts, at some point they just say they're not going to do it, or they're just going to move to a state where they're going to get paid whatever they think is appropriate. And, we understand it's all based on Medicare reimbursement, but at some point, there are costs associated with doing this. And even working for a hospital at some point is not necessarily profitable, because a lot of people, the hospitals aren't necessarily hiring people. So I get what you're saying, and I agree with you in terms of taxes or costs or raising sales tax, et cetera, et cetera. I know there are real costs, and I understand it. I'm just pointing out there's an issue. I'm not coming up with a solution, because I don't have a solution other than the fact that the governor could change us from a tier 1 payer for Medicare reimbursement to a tier 2, 3, 4, 5, which would increase the amount of reimbursement that each of the providers gets for providing the same service that is done in California, et cetera.
The governor does not have that authority.
Well, I understand.
It's a
but you could
federal
also make a
program.
recommendation.
It doesn't work that way, Dr. Glyman. It's a federal program, and the Medicare rates are not what everything is based on.
Okay, thank you.
Commissioner
May I ask a
Kirkpatrick?
question? Thank you. Listen, that is a hot topic. I feel you, Stacy, because that's what we hear all the time, that we won't come until. But can I ask this question? Because maybe we have not done an insurance study in a long time, and I'm finding myself at the county cutting benefits because the insurance rates are just getting too high for us to pay. So does it not make sense for us to do an insurance study, because that's half of the cost that, is going out the window, right? Because we're trying to remember, in this state, the difference in this state compared to other states, and I argue all the time, is the taxpayers pay it, right? Because the public employees and all of these things, and basically people have catastrophic insurance at this point, right? In the worst case scenario, my deductible is $2,500 or blah, blah, blah. But I'm wondering if it's time. I think healthcare is this session. I think we can't ignore it this session, because I think this is the cliff, right? We can't afford to give insurance. We can't wage our way out of it. And at the end of the day, the Medicaid numbers are growing. But then a lot of people are going to be without insurance, which is going to take us back to pre-2013 when we passed Medicaid to begin with. So maybe the insurance commissioner could give us some insight on what does that look like? Because when I have a school teacher that has one medication that costs $100,000 a month, that impacts everybody, right? Or when I have, I'm providing the basic insurance and it's costing $1,900. I will tell you, a single mom with a kid, is their average insurance for catastrophic insurance is $756 a month. Tell me who's making that a priority.
Yeah, and I mean, speaking from the insurance lens, it's in some ways a circular reference, right? As the cost of being able to pay for those services go up, and then premiums have to go up, pharmaceutical costs are going up. So I hear you. And, that would be an interesting conversation. I don't know that the commissioner is on today. I don't know that I saw him.
He is on. I don't want,
okay.
I don't want to put words in Commissioner Gaines's mouth, but maybe he can help me out here. Marilyn, I agree. I think there is a discussion to have there. I think the challenge is insurance rates, they're made up of administrative costs, besides Medicare, which is a different story. It's federally set, whole different ballgame. But when you look at the private market or employer-based coverage, which is often the biggest portion of what you're talking about, we have no control at the state level over those plans. ERISA plans, which is the majority of our market and payers, that's the federal government. So we can't even touch that. We can only maybe touch a third of the market. Maybe maybe a little more according to Commissioner Gaines, but with the market we can touch is Medicaid and the private market, which is really tiny in the state. And the private market you can push on, but there's administrative portion of their premium, right? That's an area we can play around with, but it's not fun. That's what we're doing on the public option. No one likes that. And then the medical side often reflects truly the cost of healthcare. And so it's a challenge to even, so I think we have to think about which markets we want to impact because we can tackle that third. But if providers are feeling, the majority of our market and their reimbursement that we can't tackle, that's why they're still frustrated because we have no control over Medicare. We have no control over the ERISA large group covered market, which is a lot of our folks. And I think that's what's so hard at the state level is to really get that side of the game to change how they operate and charge. So Commissioner Gaines, sorry to put you on the spot. I don't know if you're able to chat, but I think you could probably help me out more here. You're the expert.
Thank you, Stacy. Yeah, Stacy is right. We don't have control over the ERISA plans. We don't have any regulation of, large group. From my side of things, I don't have any control over Medicaid. That all falls to the health authority. I have small group and I have the individual market where we review the rates and the plans. Unfortunately, with our individual market, the vast majority of the people that are getting on those plans, they're the sicker population. The more healthy people they're just not getting insurance. So like young, healthy people, they don't buy a plan at all. And because we have a sicker population that's making up the pool, they are utilizing their services and their coverage to a very large extent. That is driving the price. A lot of these people, they are very ill, and thankfully they do have coverage, but they're having to get very expensive drugs. They go in for very expensive treatment and they do it on a regular basis. And, the insurance companies have to be able to price accordingly. It is somewhat of a vicious cycle. We do what we can to keep the rates down as much as possible. But if they can actuarially justify it, under the state law, I have no choice but to approve it.
No, I'm just seeing though, the ERISA plans also are getting hit, right? Because they're losing coverage because we local governments just can't afford, which is a big portion of who pays for that. We just can't afford them anymore. So I feel like it's the right time to have a conversation on how do we balance it out, right? How do we balance it out with the different options that are out there? Because I think everybody's having to make cuts, right? There is some plans too.
Okay, I am going to continue to move us along. Thank you for the deep dive on workforce. And let's keep moving. I know there was a lot of great information in the appendix too, Dylan, so thank you for pulling that together. So we'll move on to agenda item number 6, which is more of an update on healthcare workforce and rural access initiatives.
Good morning, everyone. My name is Melinda Southard, and I serve as the Deputy Director for the Nevada Health Authority for Community Engagement and Workforce Development, and would love to talk with you all about some updates on 3 of the healthcare workforce programs that we have at the Health Authority. Let's see, Dylan, are you all right if I share my screen? All right, so we wanted to talk about graduate medical education, which you guys have talked a little bit about briefly already, the Rural Health Transformation Program, and the Statewide Healthcare Access and Recruitment Program, otherwise known as SHARP. Just to kind of level set here, so we have these 3 different healthcare workforce programs in the state. They have very different lanes, if you will, for all of them. So the graduate medical education program is available statewide. So these are funds that are state funds that are available to fund any program throughout the state, as long as it's approved by the ACGME, which is the Accreditation Council for Graduate Medical Education. We had $15.8 million available in grant funds in SFY 26, which I'll get to in a moment, but we have awarded about 15.7 million of that. So really exciting that we have, kind of jump-started graduate medical education again in our state. We did award those subawards in SFY 26. So now the next step for that program is to start on the request for application for now SFY 27. We're looking to be releasing that in the fall, and we'll have about 4.5 million available in that program there. Next, moving to the Rural Health Transformation Program. One of the primary initiatives of that grant program is surrounded on workforce. The main priority of these funds for rural health transformation is that it go to rural and frontier communities. Therefore, it's very specific definitions that we use to define what rural and frontier community is. But it's very important that these funds go to support those communities in particular. We have 71.9 million available in this first year of the program, which is budget period 1, which runs through October 30th of this year, specifically to support rural workforce. And the next step on that one is that we're looking to issue all of those subawards no later than October 1st. So the team is working really hard on that one. I'll get to that one later here in a moment. And then we have the SHARP program, which is the newest program in the state. This was created by Senate Bill 5 of the special session in 2025. This program is also available statewide. These are state funds. 57.9 million is available right now to address shortages of healthcare providers, clinical services, or difficulties in accessing that healthcare, as identified in the healthcare needs assessment that Dylan just reviewed with you all. So the next steps for that one is that the request for applications was issued July 14th of this year. The deadline for those applications is September 9th, and we'll go over that here in a moment as well. So just wanted to put the broad lens on these three programs as a whole. So now we'll kind of dig down into graduate medical education and provide some updates there. So just a refresher, because I did present on this a little while ago, but the GME grant program has a governing structure. So we have the Advisory Council for Graduate Medical Education, which has some statutory responsibilities. Primarily, their responsibility is to evaluate all the applications that are received for these funds, and then to make the recommendations for funding to the Nevada Health Authority, who will then make the final funding decisions for each of these GME grant programs. Secondarily, the Advisory Council is to, study and make recommendations to the Nevada Health Authority, the governor, the legislature, about GME as a whole in the state. How do we create more programs for graduate medical education, and how do we retain those physicians, right, that run through those programs? And then, of course, recruitment and retention of all the physicians. And then thirdly, the Advisory Council is to also explore how to use federal financial participation in Medicaid to further support programs for those medical residency trainings and postdoctoral fellowships in the state. So Grant Round 8, which was awarded in SFY 26, these are all of the programs that we were able to award with that $15.7 million that we had available in SFY 26. And I do want to note that 7 of these 9 programs are new GME programs to the state of Nevada. So that's really exciting. Especially I want to point out, we do have a new OB-GYN residency, which is going to be starting up. And then, of course, we have a diagnostic radiology residency, which is another one that we've, never had in the state. So really exciting that we're able to have the funds to support these programs. All right, next we'll move into the Rural Health Transformation Program. So just a quick refresher on this one as well. The state was awarded nearly $180 million in this first year of the grant program. We expect to be awarded that much or more for each year throughout the life of this 5-year grant program. The grant program has very specific deadlines and restrictions, however. All the funds that were awarded to Nevada in this first year have to be obligated by October 30th of this year. So that means that we have to have all of our funds tied up in a subaward or a contract or otherwise spent by October 30th. And then they have to be fully spent, so liquidated, fully spent from those subawards no later than September 30th of next year. So we have 4 primary initiatives in the Rural Health Transformation Program. The Rural Health Outcomes Accelerator Program, otherwise known as ROPE, is to support behavioral health, primary care, preventative services, maternal and infant health, and chronic disease prevention. Next, we have Rural Health Innovation and Technology. This one is obviously to support innovation and technology solutions in rural Nevada. And then we have Workforce Recruitment and Rural Access, which I spoke about a little earlier. This one, we have allocated 40% of our annual award to support workforce recruitment and rural access. That one had 3 different RFAs that were released with it. So we had one for recruitment and retention specifically, another one for training and apprenticeship, and a third one specifically for rural GME programs. Then lastly, we have the Rural Health Flex Fund grant program. And this was primarily to fund capital expenditures and equipment that will help our local, rural and frontier healthcare facilities, so hospitals and other healthcare facilities as well. So some core principles for the Rural Health grant program. So these funds, as I mentioned, must benefit rural healthcare systems. Very important and is like a non-negotiable, if you will, because of the federal statute that supports this program. Any folks looking to receive rural health transformation funds have to work with those local rural and frontier communities before they're asking for funds. So we've had, some applications where it's simply been a corporate entity in an urban location and they were denied because they did not get that local support from our rural and frontier communities who need that support. And then also we have to have a sustainability plan with all these funds, because the last thing that we want, right, is the fiscal cliff at the end of the 5-year program, and just to let all of these amazing new programs that we started to just die out. We don't want that. And so every applicant that applies for these funds has to submit with it a sustainability plan that is doable to be able to receive those funds. Just some quick progress and outcomes. So for this first year of the program, we've released 10 different RFAs across all 4 of our initiatives and have received hundreds of applications. So our team has been very busy going through applications. We've had several different evaluation committee meetings, brought in, outside folks to help to evaluate these applications and, decide on funding awardees. So the first letters of intent to award were issued June 29th. And this means that, the state is intending to award these folks. We still have to gain approval from CMS. CMS is the agency who is managing these grant award funds for us. And so we have to gain CMS approval prior to executing the subawards with the subrecipients. And so, as I mentioned, we're looking to execute all of our subawards by October 1st. So to kind of give us a little buffer room between that October 30th deadline. And I just want to say here, we've worked really hard to build the systems and support needed to support all of these subrecipients. Because as I mentioned, this is a lot of money. And so we have a lot of subrecipients that we're going to be working with. It will be hundreds. Just to give a quick snapshot of some of the different RFAs and how many folks had applied, how much money was requested. Just want to draw your attention over here to the Flex Fund. So we had 103 applicants apply for, and over 188.6 million was requested. So that's over the full dollar amount that we were even awarded in year one. So there is a lot of need from our rural partners, particularly for those capital infrastructure type improvements needed. Additionally, for the RAP initiative, as I mentioned, there were those 3 RFAs there. A lot of money was requested in each of those buckets as well, especially in recruitment and retention and training and apprenticeship. The amount requested exceeded the amount that we had available. Unfortunately for the GME, we had a large amount available and not as much was requested. And so looking to work with the GME Advisory Council and our university partners to determine, how we can maybe structure that in a way that garners more engagement for the rural GME funds that are available. So far we have awarded almost 150 million of our 180 million and supporting 158 projects across all 17 counties. So all 17 counties do have rural and frontier areas in them. So I'm proud to say that, that's a lot of work that's going to be going on over this next year. Just to highlight some of the rural workforce projects that we have issued letters of intent to fund for so far. We do have 4 new GME fellowship programs that we are going to be embarking on the next year. So really excited about that. Additionally, we do have, there's going to be, we're working with the Nevada Rural Hospital Partners to provide a structure for retention bonuses for medical staff, because the last thing that we want to do is to drive competition between our rural facilities in, retention bonuses, right? Like you don't want a hospital in Humboldt offering $500,000 retention bonus and, another hospital over in Ely offering only like 100,000 or something like that. So definitely don't want to do that. So we want to have a good structure to support those types of bonus structures. We also have really excited about the healthcare career exploration programs with, our K-12 population, some different school-based behavioral health programs, working with our tribal partners to encourage more, tribal healthcare and clinic rotations in that area. And, supporting more simulation training centers. All right, and then lastly, let's talk a little bit about SHARP. So as I mentioned, the request for applications for SHARP is currently open. It was published July 14th, has a deadline of September 9th, so just a little over a month still available to get those applications in. We have 57.9 million available in funding. And I included a link here to view the RFA, but we do have a really nice website that has the RFA, the healthcare needs assessment, and then we also do a frequently asked questions document, and we update that weekly on Fridays with all the questions that we've received so far from anybody interested in the RFA, and we answer those and then provide those answers updated on Fridays on our website. Just some goals of the Nevada SHARP program. So as I mentioned, this was SB5. It created that new state general fund account to hold these funds. This is currently just a one-time appropriation. So these funds are limited. As I mentioned, it's 57.9 million available in the RFA itself. And that's because we have the 3.5% to the Nevada Health Authority to help administer the program, because there are a lot of requirements per the bill to, subrecipient monitoring, the site visits, all the things that go into administering this type of a program. And of course, we do have to seek IFC approval for the final approval on all of those SHARP grant awards. So we'll get the applications in, we'll have an evaluation committee to review and evaluate those applications using the scoring matrix that's included in the RFA. And then the Nevada Health Authority will put forward the final recommendations to IFC in December. So I'll get to that timeline here in a moment. There are some requirements of the bill. As Dylan went over, we have that assessment and report that's required biannually. And then there are very specific requirements for what types of entities are available or eligible to receive the awarded funds. And then there are a lot of requirements on the subrecipients, for those funds. So ensuring that we meet all those requirements and keep all of that moving smoothly is really important. And so then for the Nevada Health Authority to implement this program, completing the initial assessment and the report, and then to develop the RFA and, administer and sustain that program itself. So here's the timeline that I was talking about. So I kind of grayed out like past time. And so looking right now, we're trying to start hiring our new team members. So we did request for state FTE team members to support the SHARP program in the implementation at the Nevada Health Authority. So we're looking to start doing that hiring right now. And then, as I mentioned, the applications are due September 8th. So the evaluation committee will review those and recommend the applications for approval to the Nevada Health Authority, which we will then take to the December 10th IFC is the plan right now to submit, those applications for final approval. And that is all the slides that I have for you today. I did include some links down here at the bottom for each of these web pages. In case you're interested, there is a wealth of information available on those web pages. So just encourage you to check that out. And with that, I will stand for any questions.
Thanks so much for all that information. I appreciate it. Commissioner Kirkpatrick.
Thank you. Can I just ask one question? So I'm wearing a different hat. So my NACO hat, right, for all 17 counties. This has been a big topic of conversation. Could you just kind of give us a few examples of what the sustainability, because that is the big concern for everybody, what some of the sustainability stuff looks like? Should they start saving money today to cover it? What are people offering?
Sure. Thanks, Commissioner. Great question. So some of the things that I have seen is that they're, providing a new billable service. And so these funds are used to, as like the startup costs. And then as they provide those services and are able to bill for those services, those funds will come in and to sustain the program itself there. Other things that I've seen is, people seeking other types of grant funds from the federal government in future years, which is kind of, that's always up for debate, right? If you're going to be awarded federal grant funds. And, some folks, mostly it is just relying on billable services. I apologize, I can't think of any other specific examples at the moment, but I can have the team get back to you and I'll send you an email, Marilyn.
Okay, perfect. Can I also ask this though? So is that also something, because that's one of the issues that those rural communities have today is they don't have a person that can actually do those billables. And I know I see Stacy's hands go because I feel like we've talked about creating like a 4-county billable person that could touch them all. So is that included in the workforce component so we can get these high schoolers ready to go?
So Melinda, I'll let you answer that. I think some of the awards did go to some of those high school programs, but I don't know about the billable, if they're billable people, but they're healthcare professions. Melinda, did you want to answer that piece? And then I'll chime in a little bit on sustainability and kind of what came behind that or what the reason behind it.
Sure. Yeah, I have not seen personally, the request for the folks, the personnel to do those billable services. But again, I can ask the team about that. I apologize. I should have came with those details.
So Commissioner Kirkpatrick, I think on your first question, we went to the legislature, the big pushback we got about this grant. It was good reason. It's, $1 billion into the state over 5 years. And when the grant goes away, the state legislature does not want to be sitting there being asked by thousands of grantees for ongoing money. So we were trying to be very careful, right, and how we roll this out, because there isn't $1 billion in our budget to sustain all these programs. I will tell you, based on my own view of the awards that have gone out, a lot of it is one-time money that rural counties need or rural hospitals need. So a lot of it is boiler systems just to keep their hospitals going, some infrastructure costs. Some of them are coming together to do joint purchasing arrangements and other things. So that way, if we help them build something, they can sustain it together and support it regionally. Other things are once they get a technology up and built out, that's the hard part that we can pay for. That after that, it's a licensing fee that they can afford. That's their sustainability, right? It's how they're like, we can absorb it. We just can't afford the first 3 million, right? The other thing on if it's a billable service, one thought is if the counties are interested in this, they could come forward with a major proposal to say they're going to work with a vendor to set up a billing system, an EHR, or not EHR. It could be an EHR across counties. It could also be a billing vendor that works across counties. We could fund something like that. We just need counties to come forward with their hospitals and healthcare systems to make those requests. I think this first round was hard because there wasn't much time for anyone to be creative. One thing that Melinda's team is trying to do is put together a vendor funding for a technical assistance center to support grantees, because it is such a lift, and we do recognize that it's a lift for us too. So I think that's where we're at right now, but we definitely are looking for ideas like that. And if there are counties that want to have conversations while we're in this in between, the next grant cycle, we would love to have those conversations. Or if the PPC wants to make some recommendations for us to consider, I think that was the hope that Dr. Southard is, hoping to get some of that feedback today.
Okay, hopefully we can help on the PPC, and then I can commandeer the rules to come up with some creative ideas on NACO.
Yeah. Any other questions? Okay. Thank you so much for the great detail there and the update. That's exciting to see all that's started, and I know there's a lot more to come, but it's great.
Thank you for having me.
All right. So Dylan, we'll go back into the agenda. We're moving now into agenda item number 7, which is really to review and discuss and then hopefully approve some of our formal recommendations that we would like to include in our final sort of report of the year for recommendations coming from the PPC. So anything you want to start us off with, Dylan?
Yeah, just to do some level setting, the purpose of the discussion is to identify some of those formal recommendations that we want to include as part of the PPC's January 1st semi-annual report. And again, we're breaking up topics a bit so we can have a more focused discussion, with today focused on those workforce aspects. Our remaining meetings will be dedicated to developing other non-BDR recommendations as well. So there will be more opportunities if different topics aren't covered today. After our last meeting, our team gathered from multiple sources a focus set of policy recommendations from previous statewide workforce assessments, presentations to the PPC, national and state literature to develop a menu of policy strategies to address some of the challenges that we've described throughout the meeting today. That menu is categorized into thematic areas, and then we took it and did a structured impact and feasibility assessment as we did earlier in the year, analyzing the scale of and how a policy or program might strengthen the workforce, reduce shortages, improve care coordination, and kind of the evidence and literature surrounding that policy or program. And then we looked at the feasibility of each, how administratively burdensome they might be, how difficult it may be to finance or regulate. Is there precedent in previous legislative sessions? Is it operationally complex, or how does it fit into Nevada's healthcare system and initiatives? And then using that kind of framework, we identified 10 priority areas for discussion. Those higher scoring priority topics fell under kind of three primary umbrellas: workforce training and pipeline development, practice flexibility and technology, and quality infrastructure. Under workforce training and pipeline development, expanding perinatal behavioral health training and credentialing opportunities for clinicians, behavioral health providers, and affiliated professionals to kind of upskill and fill gaps as appropriate. The next is to fund career pathways and training programs to build a more diverse perinatal workforce, which again is super broad, but some specific examples include in New York, they have a state financed career ladder that moves kind of some of those entry-level roles into higher credentialed clinical roles. It's kind of an earn while you learn model. And finally, under this umbrella, strengthening graduate medical education opportunities, as we kind of discussed throughout the meeting. Under practice flexibility, developing and incentivizing team-based perinatal care models to improve comprehensive kind of coordinated care across pregnancy, birth, and postpartum. This would also help support our pregnancy medical home model concept. States like Ohio have used a similar model to support some of those team-based care practices. Another opportunity is to license and reimburse non-nursing midwives. 37 states have regulation for certified professional midwives, which can expand access, particularly in rural or underserved areas. Then a familiar topic for you all, licensure portability, and then some scope of practice expansion for different advanced practitioners as appropriate. And finally, developing and scaling perinatal behavioral health collaborative care models, integrating screening and follow-up and coordinating treatment for different mental health conditions. Finally, under technology and quality infrastructure, scaling some of those technology-enabled perinatal care models to improve access and coordination and specialty support as appropriate. There are several strategies that other states have used, including a psychiatric consultation line. One good example is Massachusetts MCPAP line. And then to ensure payment and quality incentives are aligned with the state's quality strategy and focus investments to improve performance in those defined areas. And finally, developing a comprehensive healthcare workforce database to enable better statewide workforce planning and decision-making, kind of to address some of those limitations that we mentioned earlier in that statewide workforce assessment. Here are kind of how those policies were mapped onto the matrix. Those numbers match the policy option numbers from the recommendations menu that was provided to commissioners ahead of the meeting, and is also on the website at the link on the bottom right. I want to open the floor for discussion and maybe think about, do those priority items highlighted feel like the right ones to advance? And are there options that commissioners believe should not advance or should be added as a priority?
Any thoughts from commissioners?
I mean, I think that they align with our previous discussions as far as priorities.
I would agree. Dr. Peterson?
Yeah, this is Andrea. I think it's a lot. I think it aligns. I do think we're potentially missing like pipeline development even earlier than like college age years. So I think that's an important thing because it's a lot to expect somebody just to be like, I want to go to medical school when you haven't really like given those opportunities and developed that earlier. And I think that's something that Nevada can improve upon so that we can increase our number of applicants that are applying to medical schools within Nevada. So I'm not sure that that's really captured here, but I do think that pipeline development is really important, making sure that it's occurring, you know, even earlier.
So expand, maybe going back to this slide, the career pathways to include our K through 12 as well.
Yeah.
Okay.
One of the other things I was just thinking about kind of in conjunction with the GME piece is, you know, that's a long road to get all the way to some of these specialty levels, and residents and fellows and the like they don't make a lot of money along the way. And so, you know, then they may have loans and other things. And so thinking about, are there incentives after that that could be built around staying and working in a rural environment, you know, where it's around loan forgiveness or other things like that? I'm just curious whether, I can't remember whether we've had any discussion around any programs that either exist or might be developed in that space. Dr. Peterson.
Yeah, I'll add, and I like hesitate to like even speak to this because it was just something that a conversation I'd had with UNLV's Lindsay Institute. But my understanding is that they have like a pediatrics residency that has not been filling all of their spots.
Mm.
So I think there's a big question, why is that not occurring? And again, I don't want to like go any further because I don't work with it. I know that like I've seen that written up in reports. And that's a big thing, right? If we're developing this GME, like we want these spots to be filled.
Yeah.
So
Totally.
so like are all of these spots being filled? Like why are they not? If they're not, I think it's a big question.
Huh? Dr. Walker?
I mean, to maybe answer a little bit of that question, I mean, I know when I went through residency, I was going through a residency program that was tied to the state. And so we were tied to certain reimbursement metrics and tiered according to what the state paid out for that. So, I mean, some of that maybe could be addressed, you know, at the governmental level. I did want to echo like the importance of loan forgiveness and loan repayment programs, and that might be a way to expand, you know, the funding of career pathways. I know that we have a number of international medical graduates that have come into our organization that have been stellar providers, and unfortunately, many times they go through private medical schools and come out with a truck ton of loan debt, and it's just difficult for them to work in areas of high need, especially in primary care, you know, without programs that help support the payoff of that loan debt. So if there's an opportunity to fund or expand some of those programs, I think that would be huge.
Thank you. Commissioner Kirkpatrick.
Thank you. I'm sorry. I feel like you guys want to choke me because I'm way too engaged in this committee. So sorry. Here's a thing that I can tell you that we're working on, just so you know. So housing is truly one of the biggest issues for the rural communities, getting people to go out there and work and all of that. So we have been working with the state and NACO to kind of figure out some new ways that we can do some housing that comes along with some of this, which is why when we talk about, you know, the MCOs in Arizona, they pay for housing for some of these stocks. You have that kind of a corporate headquarters incentive. So maybe when Dylan, you talk with GoEd, that's another thing that as they're coming, we should be asking them, can they help with providing housing? And some of it is manufactured housing, some of it is the smaller housing, but we're working both of those tracks because it's important to the workforce. They got to be able to have a place to go where they can afford to live and provide the service that we need. So we are trying, and I'm happy to give you all a report that's coming out in September that shows the housing needs that can coincide. That's a big reason why people don't go to the rural areas. I'll give you a crazy example. In Bunkerville, of all places, they're required by law to have a officer from Metro. There's no housing. There's no house that's been built. There's nowhere for them to live. And so now I don't have an officer because I don't have housing. And that is very common in Lincoln County. That's very common in Esmeralda. Eureka County is really struggling with that today, as well as Elko. So housing is a key component. And I do think, and I've said, maybe we could offer free housing. So we've worked with the BLM to get $100 an acre so we can build some housing that's like workforce housing within the medical field. So that's an option as well.
Oh, lots going on there. Director Weeks.
I think everything everyone has said, I would just, I totally agree with and think they're like the loan repayment, we wanted badly to put that in our RHT program, like a huge loan repayment program that would have really, I think, been impactful. It would have required that physicians who do serve our, as residents, that they stay at least, I think, 4 years. And then if they don't, they obviously have to pay the money back, but it would pay for that and housing, the whole bit. And CMS did not like that. I think there's some opinion at the new leadership at the federal level that federal funding doesn't pay for loan repayments. So that, and I think if we're going to do that as a state, we have to really invest way more than we've ever invested, more than what we can do through the treasurer's office to make that impactful. But I would say that on Commissioner Kirkpatrick, your point, I want to say, Melinda, I'm going to call you out if you can help me, remind me, or Jason, I see you're on the call. Didn't the RHP, the Rural Health Program, didn't we allow for housing for new residents to be funded through the program? Did CMS approve that? So that could be something counties and others could work on next round if we didn't get any this time?
Yes, that's correct. So we can fund housing, but it is limited to a maximum of 6 months.
Okay. So maybe we could do the 6 months with RHTP funding, right? And then maybe invest some other dollars if we can find it for the like a year long, longer. But thanks, Melinda. But I do think
And
there's
that's-
opportunity to do that more through the next round that we have. So before, maybe what we need to do with this group, Melinda and Jason, is before we drop the next grant rounds for awards and proposals, we can meet with this group to give them an update on all the opportunities so they can push it out as well. So just thinking through that, Dylan, don't let us forget. Thank you.
Yeah.
I can add,
Oh, go ahead. Go ahead, Dylan.
I was just gonna say, we can do some research in terms of what other states have done in terms of housing for healthcare. I know there is a little bit of precedent in Nevada. I know there's a Home is Possible program for teachers. So that's some models we can kind of look at and take back.
Can I ask one follow-up question on the loan repayment? It sounded like in some of those items that there were sort of stipends or other just payment mechanisms, like a pay to stay sort of scenario or something like that. I'm wondering, were those things that were getting approved?
Yes, those things were approved. I don't know how much take up we got in that space. I don't know, Jason, if you know offhand, if you can answer that right now. Sorry to put you on the spot, but I know we kind of struggled getting, maybe it was just the timeline that we had for people to respond. But Jason, do you have any thoughts on how many people took up those opportunities this time?
I don't know the numbers right off the top of my head, but there was a great uptake in the recruitment and retention initiative. And we have initiated talks and conversations with Nevada Rural Hospital Partners. And so they are helping us create some guardrails around these different stipends and bonuses that are going to be available. We've used MGMA data to help keep our marketplace secure rather than allowing it to inflate way too large. And so we're taking some good precautions. There was a lot of excitement about the sign-on bonuses, retention bonuses, the housing stipends. And so, yes, we're moving in a really good direction. I'm sorry, I don't have that number right at the top of my head, but I can produce it for you here shortly.
Okay, that'd be great. You can just put it in the chat, Jason. Thank you.
Okay.
Thank you. And just thinking that maybe having some of those targeted specifically for those straight out of residency to establish, kind of like focused on getting them established in the community and having incentives to stay in that community and build a practice. That might be a way of kind of bridging it without having it targeted directly at loan repayment. Dr. Walker.
Just another thought. Now, I've had conversations with the School of Medicine, and one of the things that they had been looking at was, true pre-health tracks when it comes to entering into, nursing or medical school or things like that. And I don't know if there's any, or if that fits in the capacity of this commission, but to make a recommendation to look for, like true pre-health tracks at UNR, UNLV, or other NSHE institutions, or even if there's more support that can be emphasized in transitioning from 2-year schooling to 4-year schooling when it comes to that. I think my understanding at UNR, and I'm not sure if it's the same at UNLV, but their pre-med is more of an advising capacity than it is like a true pre-health track. And I don't know if there's any way we can make a recommendation from this commission to try and emphasize that direction. And maybe that'll also help kind of from the high school and secondary education to the university level education transition.
Thank you. Dr. Porath.
I was just going to mention that I had dropped in the chat what loan forgiveness is available through the treasurer's office currently.
Thank you. Dr. Weeks.
I'm just thinking how we could take Dylan and also Chair, the feedback from this group. I do think it's really helpful. I think we also have an advisory committee for the rural health funds, but some of the ideas that this group is coming up with could be really valuable. So I don't know, Melinda and Jason, like timeline, maybe we can offline this a little bit with Dylan, but I think it would be helpful to have an opportunity for this group to make some recommendations, and then we can take them to the Rural Health Advisory Committee for consideration. Because I think a lot of the stuff, I think some of them are similar, but I think it does help to sort of bring this group to what we're struggling with, because you have a different group of folks as well here with different expertise. I think that could be helpful. So I don't know, Melissa or Melissa, sorry, Melinda, I'm tired. Melinda or Jason, what you think about that. But I think it would be good to have this group kind of weigh in and help push some of these opportunities out the door.
I love that cross collaboration. Thank you. Jason.
Yeah.
I agree with you, and I'd gladly come back and work with the commission here and any other entity to help us refine our initiatives to make sure we're hitting in the right directions, and that we have word going out in multiple areas so that we can get it to the right places. We are planning, and I missed part of Melinda's presentation, so I'm sorry if I'm repeating something, but we are looking at RFAs going out beginning in January of 2027. And so we will be working in preparation from now until then. And we'd love to come back to one of your future meetings to discuss this.
Yeah, and I also just want to offer that the next Rural Health Transformation Steering Committee meeting will be held on September 8th. So if there is an opportunity to have some recommendations from the PPC prior to that we can present at that meeting, that would be extremely helpful.
Thanks for that timing. That's good. We can work towards that. Commissioner Kirkpatrick.
So I have an idea. So we maybe I could pull together a separate meeting from that advisory committee and then invite you guys to come to it. Maybe the chair from PPC and then the Stacy's office, because I think if we could connect the BLM, Main Street, and the housing division to this as the governor's economic development, I think we could come up with some ways to figure out the match and to collaborate to where as Main Street is building, we connected them with building housing right downtown in the center of Ely, and that could be used for like the healthcare, and then they could get the 6 months free, and then there's additional dollars that they could use CDBG. So I'm happy to, my husband thinks I'm crazy right now. He's poking me in the eyeballs to add one more opportunity for some real collaboration with those so that everybody's coming with the same focus and say, how do we get 10 places for people to live in a fast time?
Thank you for that offer. I think that's great. Anyway, any way that we can have a multiplying effect is good. Sure. Okay, we hit a lot on some of the loan repayment and or ways to, sort of incentivize folks to establish practice and navigate some of that transition period. Any other things that maybe didn't hit the list that you would have expected for now to be on the list, or other things that we want to consider for future conversations? Anything's, and I guess I'll open it up as well. Any things that you feel like we need to take off of this list? It felt like a pretty good list that really kind of honed in on what we've been talking about a lot, but just want to make sure there wasn't anything that people thought should come off the list either.
Can I just add, this is Andrea, just making sure that those urban areas are also, I mean, there's so many gaps there as well. I think it's great, like to have the focus on rural, but there's also so many gaps in Clark and Washoe.
Yeah, thank you.
And just to clarify, we want to kind of add to this list, the loan repayment opportunities, the TA opportunities for ROPE, or for the rural health transmission, and then the pre-health tracks maybe to the career pathways program.
I might just clarify, given what Director Weeks shared, that maybe instead of loan repayment specifically being called out, that we're calling it some sort of,
We can
transition
workshop that.
stipend or something
Yeah.
like that. Yeah. Mhm. Okay. So I think, seems like we're at a pretty good list there, and would open it up for a formal motion to approve this list to move forward as a part of our recommendation. Again, I'll just say this list is the first of a few topics that we will bring over the next couple of meetings to be included in that semi-annual report that will be completed before the first of the year.
Motion.
Thank you. Is there a second?
Second.
Second from Dr. Walker. Thank you. All in favor, say aye, please.
Aye.
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 Anyone opposed? Okay, thank you.
I believe that moves us on to agenda item 8 for public comment. This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, please enter 981-401-478#. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. If joining by computer, use the raise hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
Okay, thank you, Dylan. Thanks to the whole group today for, again, a lively discussion, and to our presenters for bringing such great information. I always learn something at these meetings, and today was no exception. So we will conclude our public meeting of the Patient Protection Commission. It's now adjourned. If you want further information, you can see on the screen there where you can find all of our information. Thank you and have a wonderful weekend, everybody.
Thank you all.
Thank you.
Thank you.